Joining Dr. Haritha, Batina or Haritha Shyma. She's a registered dietitian at Apollo Hospitals, Hyderabad, and works as chief dietitian with over 20 years of rich experience in the field of clinical dietetics. She had been instrumental in planning, initiating the NCP, that is nutrition care process in the hospital, and creating and implementing critical nutrition protocols and policies. And she's a faculty for numerous allied health and nursing courses. Some of the universities are Amity University, then Indian Society of Critical Medicine, IGNOU, Hyderabad Center, Fellowship in Nutrition, Mediversity, Online University. And she's authored many chapters in textbooks and published papers in national and international journals. We welcome you, ma'am.
Able to make this last presentation interesting for all the participants. I picked this case study because it is a rare case study and we routinely do not come across these cases in the hospital, and I'm sure very few dietitians have had the opportunity to also see such cases. One, second, it's very interesting for students to know that an eye disorder can have a nutritional implications, and we can actually contribute in preventing or progression of the disease. So my topic today is a case study presentation on how a low arginine diet can help patients with gyrate atrophy. Since gyrate is a new case that we see, or a rare case that we see, gyrate atrophy is a rare inherited disease of the eye's retina and choroid. It is characterized by nearsightedness, sometimes cataract, and definite progressive loss of vision. It is a genetic defect where there is impairment in the important metabolic pathways and leads to toxic accumulation of certain metabolites, which finally and over a period of time do damage the retina and the choroid. There is extreme nearsightedness, and the retina does not deteriorate on a short period, but it slowly starts at the periphery and moves to the center, causing progressive narrowing of the field of vision. In fact, there is a tunneled vision. You'll see that during childhood, the child experiences nearsightedness, difficulty in seeing in low light, that is night blindness, and loss of peripheral vision. That means if a child is too young and cannot express this, and if you put some toys and playthings in front of them, they're able to see, but if they're to their extreme right or extreme left, they may not be able to identify them. So over the period of time, the field of vision continues to narrow, resulting in a tunneled vision. Many people with gyrate also develop clouding of lens and lead to cataract, and this progressive loss of vision could lead to complete blindness by about the age of 50. So since there is some amount of vision, this is either undiagnosed or underdiagnosed, and since there is not much of a intervention, both medically, then there's not much of medical intervention, treatment is not followed through greatly. Why does this happen? This happens because of an enzyme deficiency, enzyme called OKT. The basic biochemical defect is a deficiency of an enzyme, ornithine ketoacid transaminase, which converts ornithine to glutamic semialdehyde. Now, because this conversion doesn't happen, there is an accumulation of ornithine or high levels of ornithine in the blood, and this degenerates the chorioretinal tissue. This is a picturesque representation of how the narrowing of the retinal fields happen, and therefore there is progressive loss, or there is night blindness, or there is nearsightedness, which the individual experiences throughout life, but they're not sure about. They don't know that the vision could completely be lost. What are the symptoms typically these people see is they have no symptoms other than vision loss, but some may have additional features of the disorder, like excess ammonia in the blood, which may lead to poor feeding, vomiting, seizures, or coma. In some cases, moderate or mild intellectual disability may be seen. However, these two may not be correlated for a long period of time. So the slow, progressive, irreversible loss of vision from retinal degeneration often leads to blindness, usually by the 4th or the 5th decade of life. How are these children screened, or how do you identify or diagnose them? The only way is a genetic test used to screening for carrier status and to establish a firm diagnosis. So let's say it's there in one sibling, and you see similar symptoms as the other sibling, then you do a very early screening for the younger child. Though DNA tests, through DNA test, the exact underlying genetic defect could be identified. But if you're looking for the 5 main features, one is having the retinal lesions. Second is experiencing very early cataract by the 2nd or 3rd decade of life. Having high myopic astigmatism, blood tests revealing hyperornithemia, and autosomal recessive inherent pattern seen in the genetic testing. If you see 3 or more of these, you diagnose it as gyrate atrophy. What is the role of ornithine? And what is the role of arginine? We'll try and understand that. We see that the reduction in ornithine accumulation obtained by reducing the intake of precursors. So, we cannot reduce ornithine in a diet. We have to reduce the intake of its precursor, which is arginine. And therefore, a low arginine diet is one of the most practiced. So what is the treatment? A low treatment, if you see, there is no medical treatment as such. So there is no a particular drug which can prevent this progression, and therefore the reason why I'm presenting this case is also exactly the same, that dietary restrictions become the only form of treatment, and if we are able to intervene early, we can prevent the progression of this disorder, and to an extent you can prevent complete loss of vision. So a low protein diet, especially which is an arginine restricted diet, have been shown to slow down the function, slow down the loss of function as measured by visual field changes. So ornithine is not an amino acid which is found in the protein and is produced largely or entirely from arginine. So therefore we cannot reduce, or we cannot identify foods which are high in ornithine. We have to identify foods which are high in arginine and give and prescribe a arginine restricted diet or a low arginine diet. The only treatment which can be given, and again that treatment is nutritional. B6 supplementations have been shown to have some reduction in the level of ornithine following administration of large doses of B6. If you increase the amount of lysine supplementation is also recommended. However, that is not a short therapy which the doctor prescribes. So these patients usually are referred to an inborn error specialist, and they do put them on B6 supplementation and they do put them on lysine supplementation. However, that is not the only treatment, and they strongly recommend a low protein diet or a low arginine diet. Therefore, the only form of therapy for these patients is a low arginine diet, and therefore we identify foods which are high in arginine. So if you look at nuts, we all know nuts are high in protein, but not all nuts are high in arginine. Therefore, walnuts, peanuts, pistas, pistachios, groundnuts, cashew are particularly high in arginine. Seeds like sunflower, gelatin, if it is being used anywhere, chocolates, cheese, oats, etc., whole wheat products, soybean and wheat germ are some of the foods which can be identified. And only if these are consumed by an individual, which we can identify from a dietary recall, we need to replace them and educate the individual. I'm also presenting a brief case study on a 2-year follow-up for a gyrate atrophy. 2 male siblings diagnosed with gyrate atrophy of the choroid with high myopia were referred to Apollo hospitals. Now, if you look at the young siblings, there is a very little short age difference, 16-year-old and 17-year-old. It's a case of 2 male siblings with partial blindness identified by the parents at the age of 2, that there is something in their vision that's not very clear. So the visual defects were seen early in childhood, and this is also attributed to the genetic defect because of the consanguineous marriage of the parents. Now, when they were young itself, by the age of 2, father who's not educated but a very smart father, I could see that when the ball with which they were playing is in front of them, they were, going and picking it up, but if it was slightly towards the left or slightly towards the right, they were, finding it difficult to see where it is. So he could pick it up very early, and therefore he went to many ophthalmologists to identify, though all of them told them and diagnosed it as gyrate, they also told him there was not much of a treatment. And further, after visiting several ophthalmologists, he was further referred to an inborn error specialist, but he thought then there is no treatment, why should I go to another doctor? And he did not go through that follow-up for the inborn error specialist. He was incidentally 17 years ago, 16 years ago, also advised for a low protein diet by an ophthalmologist. But since the ophthalmologist did not give further details, probably referral to dietitians were almost nil at that point of time. This individual or a parent did not follow it up further because he felt there is no treatment and he did not attach much importance to the prescription which was written to him. It is okay. So I saw all this diagnosis happen when the child was 2, and I saw the child or both the siblings when they were 16 and 17-year-old respectively. So the case was re-followed up when the parent was looking for a partial blindness certificate in 2012 for the child's education. So until then, he did not want to differentiate. He did not go looking for a certificate. But when it was time for college and he wanted some preference for the child, he was not as able as other children. He went looking for a partial blindness certificate again to an ophthalmologist. And then this time the ophthalmologist sent for plasma amino acid profile in addition to an eye checker, and also re-referred to a dietitian. And that's when this person from a rural area landed up at Apollo hospitals only for a dietitian consult. So I was also quite intrigued that why would somebody from a rural area just land up at Apollo hospitals without consultation, without any prior appointment, not knowing whether he will even see a dietitian at this hospital. And he said that, no, I have ignored this, several years ago, and I got the same referral again. So I have come here to understand what is it that you can offer. I had done 2 cases earlier of Gyrate atrophy, so I took it up seriously. I knew I couldn't do a very flimsy overview of it, and I did a complete overview of this case. So the plasma amino acid profile was very useful because typically it's not routinely done in any of the labs. You need a genetic lab who does this analysis. So we had 2 children here. So if you classically see, ornithine is not metabolized because of the deficiency of an enzyme, and both children showed high elevated levels of ornithine. So if you do an amino acid profile, you will get arginine, tryptophan, lysine, all of that. In some cases, you see less lysine. In these cases, the lysine was fine. Very classically, one had high 700 and another one had 900, where the values ideally should be below 200. The visual acuity also was more or less similar in both the children. And me as a dietitian felt that, yes, he has to see an inborn error specialist. And I also referred them to the inborn error specialist whom I knew. Very, very incidentally, they had been referred to the same specialist with the same name, exactly the same doctor 15 years ago, but they had not followed up. So I volunteered, took an appointment with them, with the doctor, and helped him go see the doctor because he was not sure and completely in a gray area. And while the inborn error specialist re-emphasized about a low arginine diet, she also gave him this time a prescription of pyridoxine supplementation, lysine supplementation, and told that this may help. And they were asked to review with amino acid profiles and visual acuity tests in 6 months' time. So if you see the dietary call, we didn't want child to eat a lot of wheat, but he was eating chapati, puri. He was eating a lot of peanut chutney, which is so typical of South Indians. Mid-morning snacks like chips and kurkure were there. He was eating a lot of rava laddu, biscuits, noodles, etc. Again, all of which are wheat-based. And therefore, as a general dietary correction and specific to low arginine, I did the required dietary advice. Since they were already asked by the physician to follow up with amino acid profile after 6 months, I also asked them for a similar follow-up after 6 months. However, the patient came back after 1 year without amino acid profile. So the only thing that I could do was take a recall, re-emphasize to the patient directly, because this time the parent had brought both the siblings. And I also asked for a review with the amino acid profile and a visual check as and when they get it done. While it was ordered after 6 months, they got it done only after 2 years because of the studies. They lived in a hostel, so on and so forth. And let us look at how the values look like. So you will see, I also got a comparison of both the siblings incidentally, because one followed the diet pattern that we advised him and the other one did not follow. So if you see in one child, the ornithine values remained at 700, but the one who followed the diet to some extent did significantly come down from 900 to 245. Was there a difference in their visual acuity? You will see that the sibling who followed the diet and took the medication, the impact of nutritional adherence is distinctly seen. And the sibling B who did not follow the diet or take the medications that were prescribed, there is a clear-cut difference. So in one of the siblings, the ornithine values earlier were 700 and came down to 245. Other child who did not follow, from 900, it went up to 1000. So there was no improvement. In fact, there was an increase in the ornithine value by the time they saw me 2 years later. And did this impact the visual acuity by measurement by an eye specialist? The visual acuity in the child who did not follow the restrictions or follow a low arginine diet further decreased from 600 to 320, whereas the sibling B, the vision was a little better and slightly improved. Did the child sense it? Did they feel that the vision was different? One of the siblings said, yes, there is a marginal difference. So as a parent, you're not able to see that there is a huge difference. It's not that they are suddenly able to see better, but from the values and by following a diet and by following up with the inborn error specialist, at least you're able to further prevent the damage by keeping the ornithine levels in the normal range that you want it to be in. So in conclusion, dietary intervention, this case study was picked up for presentation simply because dietary intervention is the only treatment which can further prevent deterioration of sight, and it needs to be more aggressively prescribed both by the ophthalmologist and understood both by the practicing ophthalmologist, inborn error specialist, and of course the clinical dietitian. Thank you, all of you. I hope I've not kept you all waiting for too long since this is the last session. Very happy to take a question or two.